Okay, so welcome everybody to all of those who have made it actually live in person with us, and to all of those who couldn't make it but are listening to the recording. Welcome to Dr. Mizl Damayo's presentation today. I'm super excited. She's coming to us all the way from Philippines. She's usually in Florida, but today she's in the Philippines. And then we've got some friends from America who have joined us. So welcome, guys, and some New Zealanders, of course. And hopefully we might have a few more people popping along as we go. What we're going to do is I'm just going to introduce Dr. Damayo a little bit to you. Now, I came across this wonderful lady through Dr. Mark Gordon, who many of you will know as probably the world's leading experts in regards to hormones and brain health. And of course, Mizyl has trained with Dr. Gordon, and I had Dr. Gordon on the show, and he was like, "You've got to interview Mizyl." So I'm like, "Okay, who's Mizyl? I'm going to go and check her out." And so I did that, and now I've been actually working personally with Mizyl because she's been helping me with some of my mental issues, of which there are many. So she's actually my doc as well, and I wanted to invite her along today to share with you guys because she is. I've never seen a psychiatrist come across a psychiatrist like Dr. Mizyl. She is really one out of the box, someone who thinks outside the square, who really pushes the boundaries when it comes to a holistic look at psychiatry. So with that wonderful introduction, Mizyl, over to you, and we're really, really excited to have you. So thank you for making time on your visit to the Philippines and then joining us for work. So thanks very much.
My pleasure. Anything for you, Lisa. I got you. Okay.
You always have my back.
Yeah. So, anyways, can you see where the slide says
Yep.
introduction? Okay. All right. Just quick overview. I'm board certified in psychiatry and addiction medicine. I've been in Florida for over 10 years now. My main gig is Paradise Behavioral, the owner, director. I see patients as well as now a adjunct professor, and I see some of my students here. So thank you for showing up, as well as I do work as an attending at Park Royal Hospital. Don't ask me how I juggle all that. Somehow it happens. Maybe it's because of, I share with Lisa anyways, my genetics. That probably explains why.
Yeah.
So I'll get to that, as part of the genetic piece. So what I wanted to do is just have a little fun here, like how I got to where I am now. It's really important for me to actually talk about just the history of psychiatric treatment. Excuse me for a second. I need to close this door.
Yep, no worries. Yep, do what you need to do.
All right. I didn't think that somebody was going to have a big old conversation in front of my door. So but anyways, all right. So just the history of psychiatry, like, there's some of the crazy things I discovered about psychiatric treatment I really wasn't even aware of. So like the first type of mental health treatment was called trepanation. That was 7,000 years ago, where they put a hole in the person's skull, thinking that was like getting the demons out. Okay. To relieve headaches as well. And then getting a little bit more technological, they did the bloodletting in 1600s. They thought, they had the right concept. Mental illness was a chemical imbalance. And they thought, oh, you just got to bleed them out and that'll cure them. But the one interesting thing is the first psychiatric medicine, which I didn't realize actually was lithium, invented by John Kay. He was Australian, a psychiatrist that invented that. So that was pretty revolutionary because it was actually a medication now, aside from these, you know, uh, crude techniques to treat mental health issues. So the first antidepressant was found by accident. It was an MAO high inhibitor. However, it was actually a tuberculosis drug that it was called iproniazid. So there are other tuberculosis drugs that was similar sounding name, but what happened was they gave this medicine, the tuberculosis medicine, to patients in a asylum. I guess that's what it was called back then, in Kentucky. And they noticed that these patients were perking up, because if they were like pretty catatonic, But then they also noticed that it was making them manic. So they said, maybe we can use this to treat depression. We just got to be careful with people with bipolar disorder. So after that, though, let me go back here. 1952, that was the first antipsychotic called chlorpromazine that actually came from Benadryl. And after that, the first tricyclic antidepressant came from chlorpromazine, and then it was called imipramine. And it was used in depression, but their like pros were that at least it wasn't an older medicine with MAOI inhibitors. Those are medications with baggage that you really have to watch your diet or drug-drug interaction because it can cause hypertensive crisis. So, so the tricyclic antidepressant was a little bit better. However, there was still some dangerous side effects with that, especially in overdose, and cause like things like arrhythmias. So from there, though, we came to Prozac in 1987. And that was also a revolutionary step because it finally like was able to say non-psychiatric people to be able to prescribe medications and to treat depression for the masses. Much better, less dangerous when it comes to like overdose, as well as it's not as sedating, but it still took some time to build up, 2 weeks, as well as you do have GI side effects with stomach pains and diarrhea. And of course, the biggest thing about it with SSRIs, which is what Prozac is sexual dysfunction, apathy. Some people call that like, I don't feel anything, I don't feel sad anymore, doc, but I don't feel anything. That's what we call apathy syndrome. So some of the things I like to pick on when it comes to non-medications, we know Freud, he was the father of psychiatry. However, even then, the treatment was a little bit hard to do, especially for patients who are pretty catatonic, too depressed, or just don't feel like getting up to participate in this treatment. So we move on to ECT. And what was interesting is that I found out insulin was the first medication to induce a seizure in ECT. Much safer now, but that's what they used before. And then, of course, we talked about lobotomy and not so great. I think it was Rosemary Kennedy who did that, who had that, and now she became pretty much put in the asylum. But they thought that was a great thing to do. But of course, that wasn't exactly a good thing after we found out. So we do have some different options for treatment. But in spite of all these options, why do we have treatment resistance? So treatment resistance means you are unresponsive to traditional treatments. Insurance criteria, Medicare is you fail one antidepressant. The private insurances say you fail 4. But even with that, depression is still 30%. But the issue was when it comes to really what is the rate of treatment resistant depression, there was a STAR*D study, which is the mother of our antidepressant studies, 41 centers across the United States. They all like had this protocol. They all shared their data. They all like picked each other's brains, like how can we get these patients better? Even with 4 antidepressants, there was still 55% failure rate. But it gets worse because when they reanalyzed the data in 2023, it was 65% failure past 4 medications. And the more you fail, the worse your chances of recovery. Anxiety didn't fare any better. It was 50% failure rate. In bipolar, it was even worse. The worst part of bipolar disorder is the depression. 66% don't respond to the first medication. So taking this, what is the worldwide effect of mental health? 1 in 10 live with a mental disorder. That's about 970 million people worldwide. And COVID didn't help it. In 1 year, anxiety rose by 26%, depression rose by 28%. But what's really difficult to gather for people is that like you could be treating someone, but when you get the wrong treatment, it could change the brain for the worse. It can worsen those episodes, and it can make it even more frequent. And these challenges are felt by by the caregivers, and it also affects society in general. And let's talk about the impact of psychiatric illness. Um, Mental disorders are the leading cause of disability in young people worldwide. And they say by 2030, the global cost of mental disorders is going to be $6 trillion. That's a lot of money. And then the mental disorders will also increase the risk of multiple other chronic conditions like heart disease. So I saw this in my patients, treating them for 10 years or so, and I kept changing meds, and I was like, what am I doing? So I had to go on a journey to try to figure it out. So I started with genetics, and it was helpful, but it wasn't perfect. Still, I wasn't getting the results that I needed. So I moved on to like integrative medicine for mental health, and Dr. Amen was the one who really turned me on to the fact it's not about mental health, it's about brain health. I'm like, yes. And I learned a lot from him in terms of how to approach mental health from a more holistic presentation. What are you eating? How are you sleeping? Are you getting your exercise? What are your medical issues getting in the way of you getting better with your mental health? Then I added transcranial magnetic stimulation. This is a office procedure, non-medication, non-invasive. It really puts electrical charge in the part of the brain that is producing all those neurotransmitters. So I got, in general, 60% success rate, better than like 35% when it comes to medications. But utilizing all the things I've learned from genetics and learning what the supplements and lifestyle, we could get 80% success with patients who've struggled with treatment-resistant depression and anxiety. But still, what do I do with the 20%, right? So I always knew that hormones played a big part in how to treat somebody's mental health better, because a lot of women come to me in their 40s and 50s, and they're like, I can't sleep, I can't think, and I can't control my moods, and get irritable. And I was like, yeah, it's your hormones, but here's Prozac, because that's all I was taught to do until I met Dr. Mark Gordon, who actually was, I'm very thankful I met him, because otherwise I would have just learned hormones from standard ways. But he really taught me the connection between hormones and mental health. So after several years of really trying to put all the pieces of the puzzle together, I come to realize that genetics, knowing what supplements to give, adding TMS with using the principles of genetics and your labs in terms of supplementing your best success rate with TMS, and then to add hormones at the end of it all, because Dr. Mark Gordon always says it's not treatment-resistant depression until you look at the hormones, and he's right. And even Dr. Amen, one of his courses, basically said if you have a young soldier who is treatment resistant, you better be checking those testosterones, because maybe that's a problem. And Prozac doesn't help that. So what then I came to this concept was precision psychiatry. I was like, whoa, wait a minute, that's exactly how I practice. And how you define it is the use of biomarkers / labs to get to the root cause of the psychiatric symptom, so we get the correct treatment. So it's like this. Standard psychiatric treatment, we focus on treating the disease with a focus on finding the medication in hopes that we got the right treatment based on the DSM criteria. However, with precision psychiatry, we turn it around and do a holistic approach we can use medications, but we also use supplements and therapy and other alternative treatments as well that's non-medication. So we provide a total mental health solution. And knowing the neurobiological mechanisms of psychiatric disorders, you can finally get the right treatment, target what was wrong to cause you to feel bad, and to actually treat some of the things that we never even thought about how to treat with psychiatric disorders, as well as it's more specific to treat whatever symptom they have, because it's not about just treating the symptom. What's making you depressed? So maybe it's not about a medication. So, and then if we know this, then we can alter the trajectory of the disease process. And this came from precision medicine, which talks about the biology, you're talking about genetics, lifestyle, how are you eating, how are you sleeping, environment, are you exposed to certain toxins, have you had some kind of trauma, as well as the support that you get from your family and friends. You got to consider all those things to see where the block is to make sure that you are getting the right kind of treatment to be able to be successful with what recommendations you give. So in precision psychiatry, you will get the right diagnosis, you get the right treatment, as well as prevention. Sometimes I can look at somebody's genetics. A lot of people have come to me now saying there's nothing wrong with them, but I'm like, doc, I want to make sure that whatever's going to happen to me in the rest of my life, if I get stressed, if I have a brain injury, and if I have trauma, I want to make sure I'm going to get through it. So prevention, because you can be able to support people's brain health and neurotransmitter levels the right way in order for them to get through whatever it is that they may have to deal with in their life. So this is how precision psychiatry works. You have all these different psychiatric disorders, but before we even get to the treatment, let's talk data. Before I even tell anybody what's wrong with them or what I think is the right medicine, I always tell them like, I don't know what I'm dealing with. I need your genes. I need your labs. And then also get their symptoms and get their life experiences. And then you can figure out where they fit in this model of who they are to eventually get to the personalized treatment that people deserve. So this goes away from just using the DSM because it removes the syndrome-based treatment approach and it offers solutions, pharmacological, behavioral, neuromodulation like the TMS and maybe ECT, I don't know, and novel therapeutics, the things that are out there, such as the ketamine and psilocybin and other things similar to like TMS. So knowing what is causing this and knowing they get the right kind of treatment with this approach, we can alter biological process that cause these symptoms. And because mental health disorders are a collection of many different processes that interact across time. So let's just say if you have really bad genetics, but then you don't have a bad life, then more than likely you won't have struggles with depression and anxiety. But let's say you have good genetics, but you had a brain injury, you've had trauma, you've had toxins, that's going to affect how you are going to feel. And that's going to affect how you will respond to standard psychiatric treatment. So there is a Center for Precision Psychiatry, the think tanks at Harvard. Their mission is to integrate research and clinical practice so we can have more accurate risk prediction, targeted prevention, precise diagnosis, and effective treatments for psychiatric disorders. And there's the book, Precision Psychiatry, and they talk about all the things that we use for us to work up a patient, including imaging, labs, inflammatory markers, genetics, and what are our treatments. right? Is it medications? Is it therapy? Is it neuromodulation with like TMS or other things that if you think the patient fits into a certain um, classification, then that would be the best treatment for them instead of just guessing. So that is the one advantage about precision psychiatry. It's no longer a one size fits all. It is individualized treatment. And then I do like to tell my patients, you're feeling better, and people will ask you, why are you feeling better? It's like, please don't tell them. Because what could be good for you would be terrible for your friend because you don't know what you're dealing with their genetics and hormones and toxins and nutritional deficiencies and other things going on that will get in the way of if you share them what you are doing, and then it may not work for them or make things worse for them. We have to approach this from a scientific model going, what is the data? Then we can figure out what is the best treatment for them, which is individualized. So there are three components of precision psychiatry: stratified medicine, identifying the subgroups of the patients who will benefit from the treatment; personalized medicine, using genomics selected treatment with the greatest likelihood of success; and precision mental health. How do we get people to be mentally healthy, and what can we do to prevent symptoms of depression and anxiety in the future? So there are three goals: precise classification, knowing what has gone wrong; precise treatment planning, how can we fix what's gone wrong; and precise prevention, how do we keep things from going wrong? So one of the things that the actual US government has said, there are initiatives to support precision psychiatry: the National Institute of Mental Health Research Domain Criteria Initiative, the BRAIN Initiative, the Human Connectome Project, and the Commander John Scott Hannon Veterans Mental Health Care Improvement Act of 2019. So the Research Domain Criteria Initiative, this is about investigating mental disorders in order to come up with how to do better diagnosis, prevention, intervention, and cure. It's not a diagnostic guide. You still can rely on the DSM, but this is supposed to be enhancing that. And then because we need to understand the nature of mental health disease and disorders, what are the things going on and any kind of dysfunction, and what is going on with their psychological biological systems. The brain research through advanced innovative neurotechnologies BRAIN Initiative by now National Institute of Health. Its mission is to understand the brain and combination of federal and non-federal groups. And then the goal is to accelerate development of innovative neurotechnologies so it can help us create a dynamic picture of the brain, the cells, and the neurocircuit. Moving forward, though, the Human Connectome Project, which is really interesting because we take all this data that focuses on the brain connections. We're going to map the brain in order to try to see where the parts of the brain can affect whatever behavior you have. The VA has also gotten into this where they implement precision medicine. They want doctors to identify and validate the brain and mental health biomarkers, figure it out, because they want you to think about these kinds of problems: depression, anxiety, PTSD, bipolar disorder, traumatic brain injury, which is really interesting because a lot of times these VA docs totally just separate brain injury from depression. But actually, the VA said, you know what, there is a connection between traumatic brain injury and depression, and even worse is suicide. So they actually recommended, hey, use these biomarkers: functional MRI, EEG, genetics, other biomarkers, labs, so forth. So there's a lot of support to this. Unfortunately, I come across a lot of hindrance because I can't even get my veterans to have the VA pay for genetic testing sometimes, and I just have to tell them we need to go a different route, but supposedly this is their right. Okay. What I love about precision psychiatry is that it does remove the stigma, showing patients that there is something wrong, whether they were born with it or whether the brain injury caused them to have inflammation and hormonal deficiencies, seeing it in black and white. Sometimes I see my patients cry because they're like, it's just not me, doc. I said, no, it's not always about you being quote unquote stubborn and refusing to be compliant. And what are the barriers getting in the way? I think each patient deserves a good hard look, a deep dive into why they are not responding to standard psychiatric treatment. And what I love about this is that if the patient understands that there is a chemical imbalance or there is a medical cause or a genetic cause, it gives them the power to say, maybe I will be a little bit more compliant in taking what I need to take to get better. So the American Psychiatric Association, they really wanted to dive into what is the cost of precision psychiatry. And what they did was they took this study, the APA Task Force for Novel Biomarkers and Treatment, and they picked on this one particular 3 genetic testing companies. And after they analyzed everything, that you could save anywhere between $1,300 to $5,000 a year using just genetic testing alone. And depending on which one you use, it increases their quality of life. And, you save time and avoiding the wrong meds. You get to where it is that you really need to, what you need to take. And at times when you get the patient better, yeah, the disability gets better. It decreases. So what I wanted to do was talk about how do we take the information and try to translate it to clinical practice. There's 2 ways. We can either do neuroimaging, and this is a SPECT scan. This is what Dr. Amen uses. He is really good at reading it and telling you exactly what kind of mental health disorder you have based on the SPECT scan. And then the second thing is we use genetics, which is what I use mainly because I'm in a place where we don't have access to those things. So at any rate, sometimes the treatment is still the same with a different approach. So how do I use this in my own clinical practice? I start with genetic testing, and then I do what I call my Brainwell labs, Brainwell panel. And then I may add environmental toxins in there because who knows what could be getting in the way of the patient getting better because it's causing inflammation. And I will see those inflammatory markers when I run those labs. And then the Brainwell labs also includes hormone panels. So to talk about what is pharmacogenetics, what is genetic testing? So it is just the application of pharmacology and genomics together that explores how genetics may influence a response to a drug. And then it's a form of precision medicine / psychiatry with an emphasis on personalized care, looking at specific characteristics like genotypes. So I'm just going to pick on one other proof that genetic testing works because we're running low on time here. So this was a study, pharmacogenetic guided psychiatric intervention associated with increased adherence and cost savings. So that's amazing because getting my patients to take their treatment is always a challenge. It's not really all their fault either. They're cognitively impaired and they struggle with depression and they struggle with anxiety. So it's not always the best in terms of their adherence, but actually they're saying the study showed that genetic testing can increase adherence as well as cost savings. So what they did was they separated the two. I think the study was out of Harvard, and they looked at all the claims of these patients, just reviewing insurance claims, ones that had genetic testing, ones that didn't. And then what they found was they did find the ones who had genetic testing were definitely more adherent and with cost savings. And so what they concluded out of that study was you should use genetic testing in everyday clinical practice, not the last thing after you failed like 5 medications. So the people that come to see me, you know, if they're not that significantly depressed or anxious, like do something now, doc. And if they can wait, I tell them, I'm not going to do anything until I know your genetics because I don't want to do more harm than good. Okay, so there's other ones that we can do, but I'm not going to get into that now. But let's just get into what do I look for in genetic testing. There's two components that's very important to know. Pharmacokinetics, how the drug moves within the body, and what the drug does to the body. So the 4 stages: absorption, distribution, metabolism, excretion. This can actually affect how a patient metabolizes a drug. So knowing whether you need to increase the dose or not, that is, and that's exactly what I look for. If I have to give a psychiatric medicine, I want to know how much to give this patient, whether it's higher or lower, because that can also affect how you respond to the medication. But I really did a lot more emphasis on pharmacodynamics. And this is where really I got the major responses to patients. It was just really eye-opening. So when you talk about pharmacodynamics, it's the effect of the drugs and their mechanism of action, what the body does to the drug. So it's really about the neurotransmitter receptor relationship and even the transporters. So I'll get to that, what I really look for. So this is the focus now on pharmacodynamics. And I have gotten greater success looking at this versus finding the right psychiatric med with the right dose. Knowing what I'm working with a patient is exactly my ability to even give patients non-medications, natural supplements to support what was wrong all along. So brain-derived neurotrophic factor, that plays an important role in brain injury and plasticity of the brain. That's one of the genes that I look at. And then I look at the MTHFR gene. How are you able to make your neurotransmitters? And then the COMT gene, how do you metabolize dopamine as well as estrogen? And sometimes you have to look at all 3 of them to really do the right treatment, because if you're not, then you're going to be in trouble. So let's talk a little bit about why am I interested in BDNF? Well, it functions to increase the neuronal survival after brain damage, neurogenesis, and migration and differentiation of neurons. You don't just deal with one brain cell, they have to have different functions, as well as the growth of dendrites and axons. So it helps with brain connectivity. How did they communicate with each other with their neurotransmitters? And the synapse formation. That's, the connections between each of the brain cells. And what I look for when a patient is defined as altered BDNF, they are mostly what we call MET carriers. If they are MET carriers, whether they're VAL-MET or MET-MET, they are likely to have a decrease in BDNF synthesis or levels in the brain versus somebody who's just pure VAL-VAL. So, what are the symptoms of low BDNF? Depression, mood instability, anxiety, cognitive impairment. So, you can't have mental health issues just because you don't make enough brain-derived neurotrophic factor. Okay. So the good news is you don't have to use psychiatric medications when it comes to trying to increase your BDNF. One is lithium. It could be lithium carbonate or lithium orotate, and it was shown to increase BDNF in this study in patients with Alzheimer's. Intermittent fasting can also increase BDNF, and interval training by increasing beta hydroxybutyrate to induce BDNF promoters. But guess what? TMS can also increase BDNF. So this is really good for people with brain injury. And the study showed prolonged exposure to TMS increases BDNF. So I just want to pick on a little bit about MTHFR. So, I know a lot of people know a lot about it, but just to reiterate or just remind us, the folate has to be the activated form of L-methylfolate through this MTHFR enzyme that takes homocysteine and becomes methionine, and then becomes SAMe, depending on where you go, tryptophan, that makes serotonin, or tyrosine that makes dopamine that eventually becomes norepinephrine. So it's very important for us to understand the cycle in order for people to understand why it's important we really know about MTHFR deficiency. And of course, if you have too much homocysteine, that's bad for the brain. I'll get to that in more detail. If you do have MTHFR deficiency, a lot of times a common thing is anywhere between 25 to 55%. But so you do have a decrease in L-methylfolate, decrease in the synthesis, and I usually give 15 milligrams if they are just pure MTHFR deficient. So let's move on to the COMT enzyme that breaks down dopamine and estrogen. So in the brain, the dopamine gets broken down with the COMT enzyme to the dopamine degradation because you don't want to keep the dopamine too much around. It has to be broken down. And the funny thing is, just because you have COMT doesn't mean that it's one treatment. This is interesting about the gene that I didn't understand until a couple of years back, that if you are a low COMT metabolizer, meaning you are low dopamine metabolizer, then how you look at that in the genetic test is AA MET. So this is what I call if you have the warrior gene. You will have tendency to have high dopamine. So you worry, you obsess, you're anxious, you have poor stress tolerance, you can get psychotic. And I've seen this gene with people who have autism. So it's just really, maybe that explains a lot of the reason why people do have problems with anxiety and OCD. And it's very, very telling that I can actually look at somebody's genes and I tell them you're ABCD and they're like, Doc, how did you know that about me? I was like, well, I've seen it long enough, you know? And of course, the estrogen, women who are low COMT, they are more moody right before their period because their estrogen is going crazy. Okay. So, and then women who are postpartum, pregnenolone, the pregnancy hormone drops when you have your baby. And then maybe you have too much estrogen, so nothing is counteracting that. So maybe that's why you will have postpartum depression, postpartum psychosis. And so when you're balanced, though, you have good executive function. These are the people that you can rely on, you know. And so I talked about these are the conditions that you can see them in. So how do you treat that? The good news is also it's a lot of it is supplements and trying to deal with the issues of how you can bring down the effects of high dopamine. So I can share everybody the slides later on because I don't want to go through all of them, but just in general, you do have to promote immune health, try to stabilize the effects of the dopamine, as well as promote serotonin, especially if you do have issues with MTHFR deficient, but you don't necessarily have to go into treating it with L-methylfolate because that can make things worse. So tryptophan or 5-HTP, GABA can also counteract some of that dopamine, and pregnenolone. Pregnenolone is great because of the fact that it will increase GABA itself. So you should avoid things that will increase dopamine. That's what they call the phenols. So this is just in general, avoid these things if you can, you know, green tea, curcumin, all those things that make dopamine, even SAMe or even L-methylfolate can make you more anxious, okay? And the opposite is the high COMT gene, the warrior gene. This is what I like to say, because this is the one that where they metabolize too much dopamine and estrogen. And so they lead to low dopamine, low estrogen. You can have symptoms of inattention, depression, anxiety. So this is what I call the ADHD gene. And then, so you can also see this in depression, anxiety, ADHD, impulse control, and substance use. The good thing about these people is that they function great in chaos and they're great multitaskers. So these are the ones that you will see high-powered attorneys, people that work in the ER, first responders, and people that work in Wall Street. They have to do all this crazy trading. Don't ask them to be an accountant. They will be miserable. Okay. So some of the things you can do, you don't necessarily have to go and take medications like stimulants to treat this. This is the supplements, all these things, tyrosine, phenylalanine, any phenols, green tea, curcumin, amino acids, and rhodiola, all will increase dopamine along with all these lovely foods here, nuts, berries, protein, beans, chocolate, okay? Yummy stuff. And one thing that I noticed that you don't have to necessarily treat people with ADHD with stimulants. You know, I myself have this gene. So I was like, that was wrong. What was wrong with me all along? No wonder I couldn't pay attention. So I do take supplements to increase my dopamine, but I do take bupropion, which is like an antidepressant, but I use it to help with my focus and concentration and energy. And guess what? I don't have to take a stimulant because I don't really want to, you know, I don't want to be tied to that because there's ways that you can use natural things if you know your knowledge of genetics, if you know what you're dealing with, and you can use non-medications to treat these types of conditions. So that's not over yet. Okay, so I just want to go through a couple of things. This is where you get into trouble because if you don't know this interaction, then you're going to have problems. The biggest problem is if you have MTHFR deficient and low COMT, then you really have to think about, should you treat them with methylfolate? Sometimes you have to give them a lower dose, or sometimes you don't even give it to them and go with 5-HTP or tryptophan in order to make serotonin to avoid making that dopamine. So the SSRIs are the best because it'll counteract some of that dopamine. And then the other problem is, this is what I call the double whammy gene, MTHFR deficiency with high COMT, low serotonin, low dopamine, low epinephrine, as well as hypermetabolism of dopamine. So at that point, then I will give L-methylfolate and some kind of phenol, tyrosine, rhodiola, or those kinds of things. You got to support both of those issues. So the Brainwell Labs, I'm just going to go through this real quick and check this basic things. Checking inflammatory markers, vitamin D, as well as Epstein-Barr. I'm not really looking for Epstein-Barr. I'm looking for what's causing, where is their inflammation? Sometimes the CRP may not always be elevated, but their Epstein-Barr virus is super high. And I drug screen, you know, they really tell me the truth, whether they're avoiding drugs or not. And of course, the hormone panel, this talks about pituitary hormones as well as all your peripheral hormones. Because I'm not interested in just knowing your low T. I want to know, is it coming from the brain from a brain injury, or is it menopause or andropause? The treatment is different. So I just want to pick on a couple of things with why I have to look for a lipid panel. It's not so much that I think I'm worried about them having high cholesterol. It's actually low cholesterol, which leads you to higher risk of depression and suicide. We're talking about B12 too. I think with that cycle, B12 is very important. So you have to supplement in order to get the patient better. Maybe that's the problem all along. They were just B12 deficient. And the study showed it prevents the onset of depression and improves prognosis. So how much do I give? If I see a B12 below 400, then I will supplement with 1,000 micrograms a day. And if they are low COMT, but they're still having B12 issues, then I may give a little bit of B12, just half. But some people will require the injections because they've had gastric bypass. And this is the thing that's really important with, if you don't support B vitamin health, then you will have homocysteine issues that are too high, inflammation, oxidative stress, toxic to the blood vessels, toxic to the brain, impaired myelination, increased risk of dementia with plaques and tangle formation and suppression of neural stem cells. So it's interesting that we want to go into the homocysteine, why they could be elevated, different things, B12 folate and MTHFR deficiency, the C677T gene. So at this point, you can either treat them with B12 folate or L-methylfolate. But B12 is interesting because you have to know, are you able to metabolize B12? When you have elevated methylmalonic acid, is it a B12 deficiency or is it MTHFR deficiency? So if that's the case, then the B12 is high and the methylmalonic acid is high. So you give methylcobalamin 1,000 micrograms a day. So vitamin D is very good because of the fact that you have to get the inflammation down. It's very important when it comes to inflammation. It plays a role, inhibits cytokine reaction. And Epstein-Barr virus, 40%, if you've had it in your childhood, people have had it in childhood, have a risk for depression. And I get to the hormone piece. Dr. Mark Gordon is the one that taught me all about hormones and mental health. So you look at the brain hormones, as well as your thyroids, adrenals, and your sex hormones. So we can talk about, depression and all that with testosterone, we know that. But this is one thing I wanted to just say, because not a lot of people know about pregnenolone and allopregnenolone. This is the reason why women in their 40s and 50s start to talk about they can't sleep, they have lots of anxiety, and also they can't think, because pregnenolone is responsible for eating those amyloid plaques in the brain. And so that drops when you hit menopause, but doesn't mean that you can't avail of pregnenolone supplementation still. So toxins are also a big thing. If I do that, I look at heavy metals, mycotoxin, glyphosate, and BPA. I'm starting to really look at that pretty quickly. So we don't have time for that, but maybe I'll come back another time and talk really about inflammation and mental health. So once I get all the data, then I can figure out what supplements to give and what medications if I have to, and then also lifestyle, depending on which way you fall when it comes to your genetics. One or the other has to be the way that you should eat and you should exercise. And if you do have criteria for treatment-resistant depression or traumatic brain injury, TMS is a great option as part of the treatment for your treatment plan. And if you have hormonal issues, stabilize those hormones. Maybe that's all you needed to do. And of course, I do have a hyperbaric oxygen therapy. And then Lisa, our co-colleague, Dr. Scott Scher, was the one who created the protocol for me at my office. So in a way that we really just can't just ignore the elephant in the room, the organ of interest when it comes to mental health, when depression, anxiety, brain injury, cognitive issues, hormonal issues. Mental health is multifactorial. Genetics, is it toxins, is it trauma, is it nutrition, is it hormonal? We have to look at everything because we have to focus on getting the brain healthy. But the good news is, what I've culminated in my experience and research and reading and mentoring with others who know a lot more than I do, I was able to put it all together in what I call the Brainwell program: the genetics, the integrated medicine for mental health, the TMS, and last but not least, hormones. So I guess that was pretty good. At least I did good at my time. So
amazing.
Yeah. So hopefully next time we can do a deep dive in all these.
Yeah, let's do a part two. Mizyl, that was absolutely mind-blowing. I've got a million questions, obviously, and I want to let other people come to word as well. I working with you, and you recognized in my genetic makeup, for example, something that I'd known for ages, but I hadn't connected the dots to the mental health I've been experiencing, going through menopause, very, very stressful life. I have very low dopamine genetically. DRD2 genes are very low, so I don't have a lot of dopamine, always chasing big goals, etc. You identified B12. Even though my B12 levels in my blood were high, it wasn't getting into the place. So I've been having methyl B12 injections. It's made a hell of a difference, you know. So this is the nuance. I know a lot about genetics. You know a hell of a lot more. This is the nuance of that conversation, right? And things like homocysteine is such a powerful marker for us to be looking at, to be, you know, from you, and I'm learning from others, you know, how to look through different lenses. We look at our labs, and then we look at the genetics, and then we try to marry the two up. And, you know, it gets difficult. It's complicated. What you're doing is really, really complicated, but it's the way forward, right? Because there's so many pieces to the puzzle. It's not just here, take a drug, have a talk for half an hour, and off you go. That approach is really not going to cut the mustard. And the hormones is just another huge piece of the puzzle. Not that it's easy, and not that it's easy to get clinicians to work with you to help. You know, I run into the problem because I can't prescribe, of course. I can assess all of this sort of stuff and then go, where am I going to get the hormones from? Or how am I going to do this? So, we have limitations. But I absolutely love your approach. Now, I wanted to open up. Has anybody got any questions for Mizyl? You know, you're probably sitting there like stunned mullets going, what, my God. But this is, yeah.
I think you got my slide, so like you can send it to anybody, and
Yeah.
interested in looking at it. And my students, they already got an earful the first 2 days of their rotation.
Yeah.
Sure, they'll be like, oh, but it's a little bit advanced, but I want them to all be aware that, psychiatry is not just about listening and prescribing. That's part of it. But if they're not getting better with that solution, then, you got to think out of the box.
And thank you so much, Mizyl, for today. It's been wonderful. Everybody else, thank you so much for joining us. Lovely to meet you all. And we hope that our American friends, your students, Jacob and Paul and others, will join our group every month when we have these sessions. So you're most welcome to join us every month. It would be lovely.
All right. Thanks, guys.
Okay. Thanks, everybody.
Thank you so much.
Bye.
Bye-bye.